Assalamu alaikum. Hi everyone. I'm Mohammed Talaat and I'm a consultant of emergency medicine. And in this lecture, we are going to talk about the chest X-ray interpretation in trauma. As I said, I'm not a radiologist, so I'm not going to talk a lot about the alignment. This film is not sufficient. No, I'm going to go directly hit films in the same way we do in the emergency setting. Okay, so you have to have an approach, and like most of us, we go for ABCDE in trauma, and here also we are going to go through ABCDE, where A is airway, B is breathing, we mean lungs, C circulation, we are going to talk about it now, and D make it the bones, okay, and E everything else, okay. A for the airway. Hopefully, you can go for the airway margins, trachea, and main stem. And if this patient is intubated, you have to be sure that the tube is not passing more than the level of the carina, because in many cases the collapse is due to the right main stem intubation. Breathing, and in breathing, I'm talking about the lungs, and I'm not going to see the lungs first. No, it's very easy. I'm going to have a look at the lung borders all through the films, and again here on the other side. You have to be sure that the bronchoscopal markings are reaching the lateral one third of the lung fields. Then I'm going to go through the lungs itself. Okay. Whenever you have done the breathing, you have to have a look also at the diaphragm, and the diaphragm should not be connected here. If the diaphragm is connected and you can see the border of the diaphragm in the middle or the center of the chest x-ray, then this is an indication or a sign that this patient is having pneumothorax. So not seeing the diaphragm here is good. And also, if the patient is having a pneumothorax in trauma setting, mostly he is going to be lying flat on his back or her back. So you are not going to be able to see the pneumothorax easily in the early phases of the pneumothorax. And the only sign you are going to find is a deep sulcus. If you find in one side that this is very deep in comparison to the other side, this might be the only clue you have for pneumothorax. Okay, then C for circulation. I'm going to inspect the heart border. Is it larger than normal? Is it smaller than normal? Is it shifted to one side? And here at the level of the hyla, you are going to measure the mediastinum width, which is 6 to 8 according to if the patient is shot while he is lying flat or he is sitting or standing. And this is very important for suspicion of mediastinal widening for the great vessel injury. Okay, then the bones, and the bones we have usually miss are the humerus and humeral head and shoulder joints bilaterally. Sometimes a patient might be brought to you after a trauma or seizures or lightning or whatever, electrocution for example, and you are focusing on the chest x-ray itself, but you miss that the patient is having unilateral or even bilateral, in some cases bilateral shoulder dislocation. So you have to inspect the humerus and shoulder joint, the clavicles bilateral, and then you go for every rib from the posterior aspect to anteriorly. Okay, like this. And one of the clues I was taught is you have to eyeball the distances between the ribs on each side and compare it with the other side. We will see this now. Okay. E for everything else, like lines, like tubes, like gastric tubes, like soft tissue, here, foreign bodies, and this might be the only clue you have for discovering what's going on with the patient. So again, you have to have your own way for inspecting the chest X-ray. In this lecture or in this protocol, we are going to go through the ABCDE. Okay, let's start in the form of cases. This is case number one. A patient of 30 years old, bicycle hit a car. Okay, I'm going to go through the airway. Airway is more or less okay. I know that you are not very happy with these shadows, and we are sure that in all our emergency departments, this is how we are going to receive your x-ray, because this patient is on the long spinal board, and it's worth mentioning that every effort must be done to remove the board from the patient before 2 hours passed. It can cause a very dangerous ulcers that might lead to sepsis and septic shock even, and the patient might die from the septic shock even before his chest injury. Okay, so the airway, it's fine. Then the B for the lungs, breathing. I'm not very happy from this one because it's not sufficient. Then, okay, diaphragm I can see, cannot see, this is a good thing. Then I can see here. Then C, circulation. The heart is 1/3 here, 2/3 here. The mediastinum is okay for me. A, B, C, D, bones, all bones are okay. Scapula, humerus, not very well here. Okay, then E, I think we appreciate the boards, the lines of the electrodes. Soft tissue, there is no surgical emphysema here, no surgical emphysema here, and this is also the not surgical emphysema, it's the board. If you can compare it to the other side, it's the board. So for me, this is going to be a normal X-ray in the trauma setting. Okay, let's go to patient number two. Patient number two is a young female with a small stab wound above the nipple on the right side of the patient. So we're going to again go through the airway. I think you might feel it a little bit deviated to this side, maybe. And we can appreciate if the airway is in the middle or not by comparing the position of the airway or the trachea with the spines of the patient. This is the spines, as you know. So the airway, okay. Then go for B, the lungs. I'm going to start with the left side, non-injured one. Okay, and the lungs can reach the very distal 1/3 of the lung. Then when I go to the other side, well, it's a very homogeneous here, and I cannot find the bronchovascular markings except for here. So definitely you can appreciate that she's a female, and this is the breast shadow. So this is the lung, this is the collapsed lung, and this is the border of the collapsed lung, and this jetpack appearance is a pneumothorax on the right side. So again, whenever you find a finding, continue to complete your approach. So we have finished A, B. I think we need to finish the B, breathing. This is the diaphragm. Okay, and I think you can appreciate that we can see the diaphragm here, and in the right side the diaphragm should be a little bit higher than the left side, but here it's in the same level because of the diaphragm is pushed down by the pneumothorax. Okay, there is no external or soft tissue emphysema here. So A, B, C. C for the cardiac shadow, I can appreciate it here, but here it's not very well seen, so mostly it's a little bit pushed to the left side. Okay, E, we have mentioned that sorry, D for the bone, we cannot see any problem with the clavicles, humerus shoulder joint, and if you go with all the reps, you will find that there is no abnormality. So in this patient, we have pneumothorax on the right side. Is it tension? For what we have here, we are not very sure. There is a radiological evidence that this patient is having a tension pneumothorax, but always remember that the tension pneumothorax is a clinical diagnosis. If this patient is having a low blood pressure, if this patient is having a low hemodynamic instability, then this means tension pneumothorax. Tension pneumothorax equals pneumothorax plus hemodynamic instability. Okay. Patient number 3, 50 years old driver who hit an ambutal and reported left side chest pain and respiratory distress. Okay, don't be distracted by what takes your eyes here. Go systematically. This is the airway, and I think all of us can appreciate that it's pushed to the right side here. When you go to the B, breathing, you are going start. Let's start with the normal, or the one he is not complaining of. I think we can appreciate the lung field here and the diaphragm as well. If you go to the left side, well, actually the bronchovascular markings stopped here, and this is the lung border. Okay, I can allocate it. Then this area is homogeneously black, or what we call jet black. Then this is pneumothorax, and if you continue to look, that you will find the left copula of the diaphragm is pushed down, and this is the very deep sulcus. This is what we talked about earlier. So this is A, B. Go for C. C is okay. Okay. You should not be able to see the diaphragm all through this very well demarcated like this, but you can see it here because of the pneumothorax. A, B, C, D. Bones. Clavicle here is okay. Clavicle here is fractured. This might be missed. Take care. And here what we have from the shoulder is okay. Here also. If you go down here, you will find that we are having more than one fracture ribs here, for example. And if you get away a little bit and compared the distance between those ribs with the distance between those ribs, you will find that there is some crowding here and discrepancy between the distance between each rib and the other one. So this might be the clue for having some fractures here. A, B, C, D, E. When we go for E, which is everything else, we have said this is the electrodes. Don't be misled. And definitely you can notice that we have a surgical emphysema here. That's very well correlated with the pneumothorax and the multiple fracture ribs here. And again, don't forget the clavicle. Okay? Then this patient is having pneumothorax on the left side with multiple rib fractures, subcutaneous emphysema, and left clavicle fracture. Let's go for patient number 4. 20 years old male in distress after a fight. He has been stabbed on his left side of his back. Okay? So again, go for A, B, C, D, E. A, I think all of us can appreciate that the trachea is pushed to this side when you compare it to the position of the spine. Okay, it's very clear. Okay, then B, the lungs. Let's start with the normal, or the one he is not complaining of. I think you have all appreciate that it's okay here. But when you look here, well, it's whitish. Okay, whitish in the setting of trauma could be collapse or massive hemothorax. So it's whitish, and this patient is having a left side massive hemothorax. It's very clear here, and the diaphragm is very pushed downwards, and this patient most probably is going to be shocked or hemodynamic dynamic unstable. And if you remember, the definition of the massive hemothorax clinically is to have more than 1,500 ml of blood when you insert your chest tube, or 200 ml, 200 to 400 ml per hour for 3 to 4 hours successfully. Uh, when you continue A, B, C, D, diaphragm and bones, diaphragm is very pushed here, not clear, and here it's clear. Bones, well, what we have here is okay from bones, and the history does not give us any clues about the possibility of having any bone injury. E, I can see the electrodes here and don't have any soft tissue injury, the tube, maybe the mask of oxygen. So this patient is having massive hemothorax on the left side. Okay. Let's move on. This patient is 40 years old, respiratory distress after sustaining a gunshot wound. Again, go for the airway. I think all of us can appreciate that the airway, these are the spine, and this is the airway. It's very pushed to the left side. I can see, I think, yeah, I think all of us can appreciate that. Okay, then the lung. Well, the lung here is not very clear, and this homogeneous whitish opacity is very similar to this one, so I will continue from here. So what I see on the left side from the lung is okay, but when you go to the right side, well, the right side is very homogeneous, whitish. Okay, and I cannot see very well the bronchovascular markings on the right side. So, and the mediastinum is pushed totally to the left side, other side from the trauma side, and I think we have this extension from this side as well. So most probably we are having here a massive hemothorax on the right side with what we call tension component. The mediastinum is pushed to this side, and also there is some overlapping with the or extension from the right side to the left side here. So A, B, C, D bones. I cannot see any bones fractures here from what we have. Okay, in the right, in the left side, same on the right side. I cannot see any fractures. E, for everything else, I don't see any emphysema here, but I can appreciate with you that the right diaphragm is very pushed downwards here. So our diagnosis here is going to be massive hemothorax on the right side with tension component. Okay. Patient number 6, motorcyclist, head trauma on admission. Okay. Airway is a little bit more or less in the center, but actually there is a tube, ventricular tube with the radio opacity marking here. But I think all of us can appreciate that the tube is a little bit going to the right side of the chest. Sorry, the right main stem, and this is the airway. B for the lung. Okay, lung is okay. But when we go for the left side, well, there is some heterogeneous whitish opacity just in the middle of the lung. The heterogeneous opacity in the middle of the lung is going to be a lung contusion. So we have talked about the hemothorax, we have talked about the lung contusion as well, and A, B, C. When we go for C, I think we can say that the mediastinum is a little bit wide here, and it needs to be measured. If it's up to 8 and the patient is lying supine, then it can be accepted. And the heart is a little bit pushed to this side, if you can appreciate that. Okay. Then A, B, C, D, the bones. Okay, bones, clavicle. What we have here is okay. What we have here is okay. And when you go one by one with the reps, you will find that there is some crowding again here, and in comparison to the distances here. And if you go closely, you are going to find a fracture here, fracture here. So what we have here is multiple fractures, multiple refraction on the left side with lung contusion. Everything else, E for everything else, I think we can appreciate that nothing else is here except for the tube, ET tube, and it should be a little bit pulled upwards. I'm not very happy about the position here of the clavicle, but I think the patient is a little bit rotated to the right side. So the diagnosis here is lung contusion on the left side with fracture, multiple fracture reps. If you find that these fractures are more than 2 reps and more than one level in each rep, and the patient is don't wait for the paradoxical movement to diagnose the flail chest, because sometimes the patient will not have this paradoxical movement in the early phases of the flail chest due to the muscle spasm. Maybe after a few hours you are going to have it, so you have to have a very high index of suspicion in diagnosing the flail chest. Okay, moving on. 30 years old male. He had pneumothorax on the right side and still desaturated. Well, again, start with the airway. Airway is a little bit shifted to the left in comparison with the spines, as we said before. B, lungs. Lungs is okay here, but lung is not okay here, and this is the border of the lung. Okay, and this is the pneumothorax on the left side, and this is the tube inserted to help drain this air. You have to be sure that all the holes in the tube are inside the chest itself. So I think we need to either to push it inside to be sure that there is no other holes out. And if we have a patient with pneumothorax who's still desaturating and still draining, continuously draining and bubbling, the underwater seal is still bubbling with no improvement, I think we should start considering that this patient might have a tracheobronchial tree injury, and he might need more than one chest tube on the same side in another level. And if the patient is not improving, he might need to go for the a bronchoscopy or surgical intervention. I think all of us can appreciate that the heart is pushed to this side, and this is what we called earlier the deep sulcus sign. If you look here in comparison to here, it's a very deep sulcus on the right side. Okay, so our diagnosis here is persistent pneumothorax with chest tube on the right side, possible chest tube malposition or malfunctioning, and multiple rib fractures on the right side as well. Patient number 8, 20 years old motorcycle who hit a tree, hemodynamically stable. Let's go for this one by one. Airway, he's intubated. Right side, B, lung is okay. Left lung is okay. And this is, as you know, the board again. A, B, C. When we go for C, I think all of us can appreciate that this is a wide mediastinum. This is more than 8 if you measure it. A, B, C, D for, we said, the bones. If you look here, the clavicle is okay, but if you look here, well, there is a fracture of the left clavicle. If you continue, I think we can appreciate that there is some crowding here in comparison to here, with no obvious fracture line. Maybe here we can see. So A, B, C, D, E. We have a tube, we have NGT inserted, and it's in the stomach. We have the board, we have electrodes. Okay, so there's widened mediastinum with left main stem depression and apical cap. This is the apical cap. The opacity we are having here is what we call apical cap. So the left main stem is depressed in comparison to the other side. It's more depressed than normal, with wider mediastinum, with some opacity in the upper side of the left side. So this is what we call apical cap, and all these are features of rupture of aorta, and this type of patient should be sent to the CT with appropriate station to exclude or to confirm the aortic injury. Okay. Patient number 9, 50 years old motorcyclist, sustained a collision with a truck, intubated, received a thorax drain and pre-hospital in the pre-hospital setting. Airway central, tube is okay. B, I think it's okay with the chest tube, and the two holes are in. You see them, and the left side diaphragm is not very clear here. Maybe this is the diaphragm and this is the heart shadow, and the other side there is no pneumothorax for the time being on the right side. C, okay. D, E, I think we have the board again, tube, lines, tube, electrodes. I don't see any NGTs. So the right sided chest tube is in place, and I don't see any residual pneumothorax, and the left hemidiaphragm is not very clear here. So maybe we might need to pass NGT for this patient. Okay, this is the same patient, and we passed here an NGT tube, and I think all of you can appreciate that the NGT is inside the chest. If you can appreciate with me this one, and the right copula of the diaphragm is higher than the the left copula of the diaphragm is higher than the right one. So here we have a confirmed left hemidiaphragm ruptured. So the diagnosis here is still intubated, and the chest tube is very well functioning on the right side with the two holes inside the chest, but the left side is having a left hemidiaphragm rupture, and it was confirmed with passing this nasogastric tube that appeared in the left chest. Okay. X-ray of 18 years old patient who was in a fight with weapons. Airway centralized. B on the left side is okay. B on the right side, well, we have a heterogeneous whitish opacity in the middle, so this is most probably a lung contusion. diaphragm here. Okay, and the right side is higher than the left side. This is normal, as we know. A, B, C, C. Okay. The, the left border of the heart is not very well seen due to the presence of this heterogeneous opacity, which is the lung contusion. We have this chest tube inserted with the hole inside. Bones. Okay. But when you look here, you will find that this patient is having a rib fracture here. Everything else, tube, electrodes, lines, intercostal chest tube, and a bullet. So the patient is having a gunshot wound on the right hemothorax with rib fracture, contusion. After drainage, the bullet is still in place. Okay? And this is our last patient, 50 years old male, fell off a ladder, only 6 meters. The patient is intubated for some reason. A, intubated. B, it's okay. Okay. I think I'm not happy with the diaphragm on the right side, not very well elevated than the left side. It should be more elevated than that. I don't know. Okay, and you might find that there is like a double shadow here. I'm not very happy, but actually the lung is reaching. Okay, so let's see. A, B, C. The only thing here is I'm not happy with the very sharp edge here and double edge. A, B, C, D, bones. Okay. E, everything else, nothing. Well, this patient is, for me, might be normal, but I'm a little bit suspicious for the right side hemidiaphragm that is not higher enough than the left side. And I want to tell you that when we have CT chest for this patient, and this is the cut at this level, almost this level. If you look here closely, you will find that there is a rim of pneumothorax on the right side, and you might not be able to see it on the x-ray initially, because when the patient is in the supine view, you will not be able to see the very well demarcated pneumothorax in the lateral aspect of the chest, because it will go ventral, like here in the anterior side of the chest, and it will be a very thin rim, and you might miss it. So you have to go hunting for it. You will find that the sulcus is a little bit deep, and diaphragm is almost in the same line of the other side. This could be the only clue for this, and you have to be very suspicious with the pneumothorax. So chest CT is here the diagnostic tool to be excluded, and it confirmed the presence of pneumothorax on the right side. Okay, folks, thank you so much. If you have any questions, please leave it in the comments, and I will get back to it. Thank you so much, and see you.